I just wanted to have a warm welcome for our next speaker, who is Dr. Maureen Shannon. She's a professor at the School of Nursing and Dental Hygiene at the University of Hawaii at Manoa. And she's a midwife and a family nurse practitioner with years of experience as a clinician, a researcher, and an educator. She's also the principal investigator and project director on a HRSA grant and the Hawaii Interprofessional Education and Collaborative Alliance project. And want to give her a warm welcome today. Thanks, Maureen.
Aloha.
Aloha.
How many of you have been to Hawaii?
Yes.
Raise your hands high. Okay. So you know when you hear aloha, you got to say it back, okay? All right. Good afternoon. It's really a pleasure to be here. I really am excited about this topic because we've been involved in an initiative in Hawaii now for a few years looking at interprofessional collaborative practice education, and basically I moved that forward to actually implementing it in a school-based health center in Hawaii, and it will be implemented throughout the state. So I have no conflicts of interest that I know of. I will state I'm not a dentist, a dental hygienist, dental therapist, a dental assistant. I've never taken a dental class in my life, but I've gone to the dentist many times. I will also state that I'm an alum of the School of Nursing here, UCSF. I got my graduate degrees here, so things look very familiar to me. So I wanted to start with a nice picture of where I live. Some of you are familiar with this place. If you've gone to Oahu, on the windward side or the east side is Kailua, and it's got a 2.5-mile beach which starts right here, right, and goes, it's a crescent, and it's a beautiful place to go. The little beach you're seeing in front of you is the beach that Obama uses when he visits. So I actually live adjacent to, on a canal right across from where he stays. Why I'm showing you this picture is because the environment of Hawaii, as you know when you visit, generally is conducive to being active and engaging in healthy behaviors and lifestyles. And I just read recently the obesity ratings for the states, including Hawaii, and basically we're doing pretty well in terms of rates of obesity. We definitely have obesity there, but compared to other states, it's not as great an issue as you will see in other states in the country, because most people are moving around and have to be active. The one thing that we are not good at is oral health. So you're all familiar with this, I'm sure. You've probably read it, read the whole report, or read parts of it. But one of the things we do see, and you see here as well, in your school, but also in the states, mainland here, is the disparities between the people that need oral health access and those that get it. And that's very true in Hawaii as well. The challenges we face in Hawaii are very similar to what you face here, with some exceptions. Our geography, as I'll show you, it's beautiful and we love it, but we have 4 counties and none of them are connected to each other. They're all only accessible by air or water. So you can't really go to another county to get services that you might want, unless you have a lot of money and a lot of time. There's a lack of fluoridated water in the state. We'll talk a little bit about that. The only places that have fluoride in the water are the military bases. So none of our population in general gets fluoride in the water, and we don't have natural resources of fluoride that would be ample enough to actually provide that support, that prevention for children and families. We don't have a dental school, and I don't think we'll have any opportunity to have one in the near future. We just had a conversation about this with many of the colleges. We do have a shortage of dentists, and we do have a maldistribution of dental providers. And I'll show you in a minute what that looks like on one of our islands. In 2009, we had an economic crunch nationally, and the consequence of that for the Department of Health in Hawaii was to start to cut things back. They had no option other than to do that to be successful for having any health services provided generally for the state. And what they disbanded was the dental division of their department. So they lost the dental director, and we lost all our dental hygienists that were working in the field to promote oral health and prevent caries development. That's changing now. About a year ago, Dr. Gavin Yoshida, who is a pediatric dentist and a friend of mine, is now the dental director in the state, and he is very much focused on moving forward the oral health of the state. It's a state agenda item. It's a priority. It's probably one of the top 10 priorities for the state at this point in time. In our population who needs Medicaid, and there's a great number of them, there's no dental coverage for adults. Only emergency access coverage, meaning your decay has to be so great that you're going to the emergency room, and the only option is to basically do extractions. So they have emergency coverage, but no ongoing preventative care. Cleanings, exams, none of that happens unless you're a child. And primary care providers, although we've been trying to work with them, I'm so excited that AAP was talking about this morning. We have some of our pediatricians, some of our family practice docs are trying to learn and implement doing fluoride applications. But I have to tell you, it's not a large percentage. I will tell you that in our School of Nursing, we have 2 primary care nurse practitioner programs, family nurse practitioner, adult gerontology nurse practitioner. They're primary care focused, they're not in the hospital, and all of them are learning how to apply fluoride, and all of them are considering we're looking into SDF applications as well. We have a geriatric population that cannot access oral health services, especially in long-term care facilities, and their mouths are full of caries. And then cultural beliefs, and I'll talk a little bit about that in a minute, because you'll hear stories, you'll hear people talk about Hawaii, and the belief that the environment should not be in any way tampered with under any circumstances. It's called mana. And there is a cultural belief that doing anything like water fluoridation would actually be impairing the natural environment, and it actually would be a taboo. So that's where we are in Hawaii. For those of you who travel there, you know it's about a 5-hour flight from California. Our nearest state is 2,400 miles away. And we're one of the most isolated places in the world in terms of violence. Oral health in the children in Hawaii is, keiki is the word for child or children in Hawaii, just so you know. So, we have about 15,000 children under the age of 5 that need Medicaid and are getting it. We have about 150,000 more children who need Medicaid. And if you look at those numbers, and you have to multiply that by about 6 to 10, because their families also need Medicaid. So that's how many people probably are needing it. In 2015, there was a statewide surveillance and assessment of all 3rd graders' oral health. And what we found was 70% of those children had evidence of decay. And 25% of the children with evidence of decay had untreated caries. 60% of the children do not have sealants, partially because there's nothing to put sealant around. They don't have good teeth, or they need restorative care. And some of the others just are not getting it. Okay? We're doing a surveillance now, and it's probably going to be done in the next 4 months, 3 months, of early Head Start. So we're looking at children 3 years of age to see what their oral health is, because we really want to find out what can be done for those children. What is the status of those teeth before they hit age 7, 8, or teens? So dentists make up, the dentists we have predominantly are generalists. They're not really educated in pediatric dentistry. And only about 1/3 of the dentists we have will accept Medicaid. Okay? So you've got maldistribution, and you have 60% saying you've got to have insurance or pay. Less than 4% serve pediatric populations, and of those, I know for a fact, many say they will not see a child until they're 2 years of age and older. So you've got a 2-year gap between when you could have somebody talking to them, in addition to a pediatrician, a family practice, or a nurse practitioner, where they're not seeing anybody. And by the time they come in, I've seen children whose teeth are actually needing to be extracted at age 2. And not all dentists nor primary care providers provide fluoride supplement prescriptions, and not all of them do applications. If you think about generalists, they've got a busy practice. They've got everybody from the baby or the kids all the way to the old people coming in. And so they may not be thinking about, I need to write a the child needs supplementation, I've got to write a prescription for that, I've got to go to an application. Many of them don't have time, they're not thinking about it. It's not part of what they see. All right? So this is the big island of Hawaii. This is Hawaii County. How many of you have been there? Volcanoes? Okay. Beautiful place. Very small population. Less than 200,000 people live there. The entire state of Hawaii has 2 million people. That's it. About 1.2 million live on Oahu, Honolulu. About 800,000 live in Honolulu itself. So when you look at the rest of the state, everybody else is dispersed all over these rural areas of our state. So I can't show you, but if you look to what would be your right, up in the corner there, you'll see the big island portrayed and all the other counties we have. So there's 7 islands that constitute the state, 4 counties. And all but Oahu are considered rural, and all but Oahu are considered underserved areas, and justifiably. So Hilo is the big city. I don't know how many of you have been to Hilo, but as far as cities go, it's kind of a small city, very tiny city, big town. And then on the opposite side, closest to me is Kailua Kona, which is another beautiful area. If you look at the red map, the red little circle with line, those are the roads. That's it. So there's parts of the road that are only 2 lane. One way going, one way coming, and that's it. So when you have to go somewhere for services, you have to plan it's going to take you a couple hours to drive there, if you're lucky, and there's no car accidents, and nothing's happening in terms of school buses picking kids up, picking them off, garbage trucks, whatever. You have to factor that in. We have people that go from the very southern part, that's Volcano, all the way to Kailua Kona, and from the very top, Waimea, all the way to Kailua Kona for WIC, Women's, Infants, and Children's Services, and many of them go that far to get dental services and healthcare. They do have healthcare in Waimea and Volcano, but they don't have necessarily pediatric dental care there, so you're looking at a very, very, very challenging thing. Our dental director for this state, Dr. Gavin Yoshida, does fly in once a week to Waimea, and he does see patients there, pediatric patients there. All right, so we went to WIC. The DOH, Department of Health, asked us to go there to look at what was going on with the program they had set up. So my colleague and I, my colleague Dem Matias is a pediatric nurse practitioner faculty at UHA with me. We're kind of like Tweedledee and Tweedledum of the oral health world, the School of Nursing. So we're going all over the place working on things to get kids' teeth and mom's teeth better, and actually families. So I'm a family nurse practitioner by training. So they have a project there. They have the West Hawaii Pediatric Dental Clinic, which is a beautiful clinic, and it was just refurbished. They love children, they love families, and they live about, their building's about 5 blocks from WIC. So they go once a month to WIC and do an assessment of children's teeth and apply varnish, make sure they get the fluoride supplements they need, whatever. But it's only once a month. And what we looked at was, are the nutritionists there able to sustain kind of the education that parents need and access services for other children that are coming in the days that they're not there? What we found was basically that they did the best they could, but there was no consistent message that they gave because they're busy. And they didn't really have handouts that were easy for somebody to read. Again, we were looking at literacy levels for 3rd grade reading because many of our patients we see are immigrants, and even if they speak English, they may not be able to read very sophisticated materials. So we were sent there, and basically this population is primarily Native Hawaiian Pacific Islander, or part Native Hawaiian, part Pacific Islander. We do have Spanish-speaking patients there, and we do have patients who have come from India to work. On the Big Island, the plantations are primarily the biggest economic thing they have going there. So coffee and macadamia nuts, we've got those plantations everywhere, and they need workers. So a lot of times we have people that come from Central America and India to work there. What we found is all the people that were seen at work are economically disadvantaged. They have to be, that's a requirement. And they reside in rural areas. Kona is kind of rural, but they were residing around Kona, and some of them were coming, again, from Volcano, Pu'a, and the Waimea area. So we had just 50 families, which was fine. We had 73 children. Almost 70% of the children who had teeth Maureen had been seen by a dentist within 12 months before we had started talking to the parents about this. We surveyed them. However, only not even half were getting fluoride prescriptions, and about less than half were getting fluoride applications. So they were seeing dentists, but they weren't getting what they needed. The mother's dental care was worse. Half had not been seen in a year. 25%, 26% had not been seen in 2 years. And I will tell you that most of them had not been seen in 4, 5, 6. I had one woman come in who was 4 months pregnant, 2 WIC. She just had her first visit the day before with her obstetrician, who said to her, "You are going to the dentist. I am calling now." The last dental visit she had was 12 years ago when she was pregnant before, and they flew her from Maui to the Big Island, to Oahu, to have her teeth pulled. So it's a problem. And we have to really, that's why I'm standing here talking about what we've done. The other thing that was interesting is people wanted to know, I said, "Dad, we got to find out what they know about fluoride, because they may not understand what fluoride is." And certainly that's what we found. About 50% of the people that we saw, was 50 families, only half of them kind of knew what fluoride was, kind of, like sort of, like it does something to your teeth. The other 50% had no idea. They didn't know what it was. So you've got this thing circulating around about fluoride and how dangerous it can be, and it's bad for putting in the water, and nobody really knows what it does. So what we found when we just told them in one sentence, very simply, this is what fluoride is. This is how it goes on your teeth. This is what it does for your teeth. Very simply, nothing fancy. And what happened was we asked if you knew that it could reduce the risk of your child having cavities by about 50% or half, how do you feel about having your child have these things? And that was the answer. So all this stuff about they don't want fluoride, they don't want to hear about fluoride, and I'm sitting there going, this is crazy. 80% of them want water in the fluoride in the water, 80%. We weren't telling them they should do it, we were just asking the question. And the reason for that was because of those people we saw, many of them had had caries as children and were embarrassed by their teeth because they couldn't smile. Their mouths hurt when they ate, and they had to have teeth pulled. So they know what it is to have bad teeth. And almost every one of the mothers and the fathers we saw valued their children's baby teeth. They knew they were important. They just didn't know all the details about that. So I'll tell you, excuse me, we're replicating the whole thing in Kapiolani Medical Center in on Oahu. They have a WIC there, which is a much busier one, and we're finding the same kind of responses. Overwhelmingly, they want to have their children have preventative oral health interventions. So I looked at Deb, and we went back to UH, and I said, "Oh, you know, we got to do something. We don't have a dental school, so we got to look at our dental hygienists and see what we can do with them." And that was an automatic kind of like, let's get them out there. They have to get out of here, out of UH Manoa. And I'll show you in a minute where we are. We needed to look at how we were going to identify dental homes. The Wikakona does a really good job, but I'll tell you that it varies from WIC site to WIC site how many people actually know where a dentist is who will take a child. And Deb and I have worked with a grad assistant we have, and we've mapped every single dentist and every single pediatric dentist and every single pediatric dentist who takes Medicaid and a child, what age they take them for the entire state. And I can say that maldistribution is contributing to it, but I think a lack of knowledge is who's down the street from us. In fact, at Kapiolani, there's a pediatric dental practice that's literally across the building in a tower where the offices are. And I said, I'm going up there and finding out what the story is. And I just said, here's the cards, we're bringing them down. And they said, yeah, bring them over, we're happy to see them. So they didn't know about that practice. They were in the same building, the same services. So we're engaging primary care providers in preventive oral health. As I mentioned, all of our nurse practitioners are learning about fluoride applications. And probably we're looking at SDF as well. We have to talk to Gavin Yoshida and some other people about that. Capitalizing on school-based health clinics, I will talk a little bit about that if I have time. We're addressing health literacy. Part of the problem is how you teach people something about fluoride. So simple statements. We made a little pamphlet. It had 3 little sections, and there were 3 bullets under each one for the different ages of a child and what they needed for oral health. That was it. And for mothers, 2 sections. This is what you need to do to stay healthy in your pregnancy, avoid drugs, smoking, whatever, 4 bullets, and on the other side, 4 bullets about oral health, what you need to do. Very easy, people loved it, and they're giving them out like candy. Oh, that terminology. Anyway, address low reimbursement rates for flight applications. That's one of the things that we hear from the primary care providers. They say, I'm only going to get $4.50 back for doing this, I don't have time. It takes longer, it takes more money to bill for this, to do the billing, than it does for what I'm getting. Now in Florida, you get $35. So that's kind of like, oh, we're interested, we can do that. That's cost effective, they can see that coming into their practices. All right, so opportunity knocked. In this case, it was HRSA again. And when I say opportunity knocked, it's like, yeah, my dean saw that HRSA announcement before any of us did, and I'm like, that's fine. And when opportunity knocked, she says, this looks very interesting to me, Maureen. I want you and Deb to think about looking into this, which means you need to write this, basically. You need to figure out how we can do this. So I went to the big house. This is Manoa's campus. This is Hawaii Hall. For those of you who've been to the campus, this is Barney's Circle in front of you. And the School of Nursing is about closer to you. I'm taking a picture from our School of Nursing, actually. Dental hygiene has a clinic on the campus. It's about a block from down the road from Hawaii Hall. So it's centrally located. It's not far away from where the students can get services, and children, if they're in daycare, there can get services. But they really have not had their dental clinic, their dental hygiene clinic has not seen pediatric patients for probably 10 years before I got there. They're resuming that now under this grant because they realize that this is really an important aspect of what we have to do. So we went to the office of the dean, and she said, what do you think? And I said, okay, hold on. So we wrote a grant really to increase dental services for children under the age, 5 years of age and under, primarily by enhancing what we already have in our dental hygiene program, which is increasing pediatric content and clinical experiences in the existing baccalaureate program. In addition to that, it's getting them into the community to provide services with mobile dental units. They're not going to stay in the clinic alone. And then we've implemented an early childhood or pediatric-focused expanded dental hygiene certificate program. It's a year long, and I'll show you that in just a moment. But that's to really give somebody a special training and education in pediatrics, developmental stages of children, assessments, that sort of thing. It's very, very intensive, pediatric focused. And we're hoping that will decrease dental disease, decrease costs to the state, and absolutely impact beneficially the oral health and the systemic health of children, and ultimately their families. So that's what we did. Now, I'm not a dental hygienist, but I sure learned quickly. So we work with our dental hygiene faculty. The chair of that department, Christina, thought it was wonderful, and then Melinda Lau, and their team, the faculty there. And Deb and I learned everything you could imagine about everything we thought we didn't know, obviously didn't know. And CODA, because we have our friend, we know CODA, we read all the legislation, and then we started to work on doing what we said we would do, which is really creating a curriculum that's child-centric and can help with the whole idea that we can do this in the community. So the training sites right now, we have the dental clinic, they're resuming pediatric clinic days once a week, starting in fall. We have early Head Start, and we have MOUs with memorandum of understandings with Head Start, so we will be going and providing services at Head Starts. We have federally qualified health centers that want our dental hygiene students to come and participate there. And we are looking at moving into web clinics as soon as they just had a change in leadership there, so we're not going to bother them. We have enough with Head Start the first year. And again, all of this is going to start in fall. We're also working with NYU's Langone Lutheran Pediatric Dental residents who are in Hawaii. There's about 10 of them total, I think. They take 5 every year. They have a 2-year rotation there. And we're integrating them into the dental hygiene, both didactic and also the mobile units, and as part of our interprofessional collaborative practice model. So this is what we did. We went through every single course and identified those to modify, put in new objectives and kind of new books and things to read. We served our dental hygiene graduates to find out what their comfort level was with pediatric services, providing those. And by and large, the majority of them said, I'm not comfortable. I'm not. I will do it if I have to, but I really don't know. We obtained the dental hygiene faculty and approval, obtained an advisory board that gave us input about what we were doing. And then the next steps is to implement this baccalaureate, revised baccalaureate curriculum in fall. And we have didactic content that includes evidence-based research, which was really not evident in what we were reading, as well as practice guidelines and interprofessional collaborative practice principles. Clinical experiences are going from 1% to almost 15% of the baccalaureate students, which is a big jump. The expanded function dental hygiene program is 2 semesters, 16 credits total. If you look here, 11 of the credits are clinical. So they're really getting in the field and applying. They're already dental hygienists. They have to be when they come in the program. So now we're going to say, we're going to really do this for pediatric populations. And it's community-based practice capstone is required, which will be field work and working with an agency and organization to increase either education or utilization of their services. And again, they'll start in August. And they'll get a certificate from our university that says they specialize, they completed a special training in pediatric oral health. So we are looking at education and prevention versus emergent care. We're not looking at restorative care. That's not part of what we planned for this. We have to take baby steps in Hawaii. Things move a little slowly there. So we're not throwing everything at one time to the population. And we've gotten great support from the community about this, including our dentists and our dental hygienists. So these are the things that they're learning, assessment and preventative measures that they can use. And this is the curriculum, and if you look at it, there's a lot of didactic here, but only 1 credit. But there's a lot of clinical time, and they will spend time in interprofessional collaborative practice and simulations with teams of people that are not dental hygienists, so that they'll be part of the team and not forgotten, like, oh yeah, we should think about dental hygiene. Like, no, they're here, and yes, they're part of the team. So that's what that looks like. Our measurements, we're going to increase, we want to see how many children we actually do have getting care through these new curriculum and clinical experiences of our students, but also we're going to be using mobile units, and we want to get out in the community. So how many we have, and we want to increase those every year of this grant. It's a 5-year grant, so we have 4 years of implementation, and every year we're expected to get more and go out and do more. And when I say that, the picture of the islands of Hawaii, we're already going over to the Big Island 2 area where they're not getting services, and the next step will be Maui and then Hawaii. So we're really moving our dental, expanded function dental hygiene students are doing that with senior dental hygiene students. So they're going to learn how to use this equipment and be ready to go. We really want to increase dental home access. I like to call them health homes or health clubs. I always get worried because there's so many homes that we have to go to that I get confused. I just feel like saying, why don't you say it's a health club and everybody will feel very healthy. And then go to the dental health club. Increased enrollment of our Native Hawaiian Pacific Islander students in dental hygiene. We'd really like to have them come. Their perspective on cultural aspects of how to provide services are very helpful, and we'd like them to be able to come and provide services to their communities. So we are working hard to do that, and we're having dental residents join us. I'm hoping they're going to join the interprofessional team practice. We have a goal next month, but definitely in the dental hygiene program next year, year after. Okay, and definitely we're going to expand dental hygiene and dental residents into the school-based health centers we have to integrate interprofessional education and interprofessional practice. So this is this is Dole Middle School. This is where I go every Thursday to practice. I'm overseeing a team there. So we have 15 districts, school districts in Hawaii. We call them complexes. They're throughout the state. And the Department of Education is in charge of all of those. So there's no county by county change. It's across the state. When they say this is what's going to happen, it's going to happen. You don't have to worry about it. So for a few years, we've been testing school-based health centers, about 7 pilot sites that our dean worked with Department of Education to create. And they're all practices that are for pediatric nurse practitioner or a family nurse practitioner in charge of that school-based health clinic. That's her practice site. She sometimes has RNs under her at different other schools in the complex, so we have children from kindergarten all the way through high school in a complex, and as you know, you have different needs of children, different developmental stages, so you have to be prepared for whatever's going on there. So technically, the nurse practitioners are in charge of the complex healthcare needs of all of those children, and we're talking thousands of children. Dole is located in Honolulu, Kalihi Valley. It's pretty much almost all Native Hawaiian Pacific Islander children, and I would say there's a fair amount of the children who are recently immigrating from Marshall Islands or Micronesia. So they are having English as a second language and learning it. So we go, and our team there consists of the advanced practice nurse, the family nurse practitioner there, Melissa, is in charge of the team. This is her practice. But we have faculty from the pharmacy school of pharmacy on Hilo, UH-Hilo. We have a child adolescent psychiatrist who is there as well from our School of Medicine Department of Psychiatry. And all three of us have students that are there. So the students rotate about 8-week sessions together. We're kind of like a team. And what they do is they really actually do practice as a team there. So everything is done in that room here. They have an examining room, and they have several little cots that children can lie down on if they're tired, and then there's several chairs that they can sit around while they're waiting to be seen. And I can tell you right now, I was enjoying the pharmacy, what the pharmacist was saying, because I was laughing one day they didn't have a medical assistant one day or for a couple of days. And I have to tell you that every single student was checking in vital signs, weights, doing BMIs, what's wrong, how are you doing, what do you need, getting their stethoscopes out and starting to assess kids. Because they really needed it, and we had a backup. Sometimes Melissa will see up to 40 students in one day, and sometimes there's 10 of them lined up to be seen. So it's quite interesting to see how it works, and we've always wanted to have dental hygiene with us at a dentist. And the dentist who was supposed to be part of this was Dr. Gabby Machida, who right when we were launching it became the dental director, and we said, oops, this is not going to work. He won't have time for it. So we're going to integrate the Lutheran pediatric dentist. So, statewide impact, I think it's pretty clear. We're going to help the children's health improve, both orally and systemically. But I also think that you're going to improve the family's health as well. They learn about why their children's teeth are important. They'll learn their teeth are important, and they know how to take care of them better. So we do family education as much as we can. And then we try to assist in identifying medical homes. We're going to see, we're going to probably see decrease in families' costs, because some of these parents, many of them, they're working 2 jobs a day. They can't really take time off. If they do, they lose a lot of money. And so they have a tendency not to do what we suggest because they don't have time. So we're going to see that if you take the care to where they live and they work and they play, then the parents won't have to worry so much about losing work and money. Reduce school absenteeism is a huge priority for the Department of Education. Dole Middle School had an absentee rate of about 35%, chronic absenteeism. So you've got 800 students, and you've got, any given day, 30% of them not there. And that's just not going to work. So sometimes it's because they're sick, or they don't feel good, or they have a toothache and they have to go to the dentist. And then improved education of the families. And statewide, obviously it'll be an economic impact, reducing state funds for restorative care, because we're doing upfront preventative care. Hopefully that's going to be good. We are reducing the cost of transport from people on the neighbor islands to Oahu for extractions and dental disease care. One year, I think they spent almost $850,000 just flying people over, not even the procedures that were done, and that's a lot of money for a state to pay. And basically, we're going to increase the dental workforce caring for children. We're going to target children now because of this grant, but we really want to do this and roll it out. So if you're seeing children at school-based health clinics, you can expand those services to their families very easily, because you've got a center and you've got a community there that you can readily access. So. And then we're going to increase access to the dental homes. And this is an acknowledgement. This is the HRSA grant we got. We always have to put that in there. We're very grateful to them. We just put in our progress report. We're hoping we'll keep getting funding. And this is the really important acknowledgement. The people on your left are a grant team that developed this, and Deb Matias is a PNP. That is the project director. I said to her, you take this one, I'll be the mentor. So I'm on the grant as a senior mentor overseeing all of it, but basically this is hers. And Christina Sada, she's the chair of the department. Melinda Lau, who's a faculty with us, so they're both on the grant. Martin Uishi is a longtime dentist who's been working at the dental hygiene program, and he's wonderful. Lynn Fujimoto is our pediatric dentist, and she's the director of the NYU Lutheran program for the state. And the last three people, Beth, Jim, and Marla, are administration, and we could have them, so I'm thrilled to have them on there. And then these are our community support people. Most of them have members on our advisory board, and they're very helpful, and they're very excited about what we're doing. So you can see that we have a strong support mechanism, and hopefully this will help make a dent in what we have as a problem, a big problem in Hawaii. Okay. That's our references. Mahalo. Any questions? I'm happy to take. Yes?
Just out of curiosity, what percentage of the current hygiene class is interested in doing the additional year focused on pediatrics?
You know, that's a great question. We surveyed the graduates to see what they would be interested in, and quite honestly, we had, I can't remember the end number. I have a piece of paper. Well, actually, no, I have it here. But anyway, we had 65% of the graduates wanted to come back and do this. Because they were seeing, we also surveyed them and asked them, how comfortable are you seeing a pediatric? And they were like, I don't know. But they're seeing pediatric patients because maybe you work with a generalist, but the generalist is seeing pediatric patients. So this is a marriage made in heaven as far as I'm concerned. You know, these people could go with a generalist and hear, I got a pediatric specialized dental hygienist here who will help us with our kids. Great. So a lot. We're having people in the community, which right now we're targeting the students that are in the program now. So when they graduate, we have 3 of them that will start next year. We're starting very small because we have a whole baccalaureate program that we're changing. So we had 3 definitely are coming. There's no problem with that. But from the community, we got people that have been practicing dental hygienists. They want to come back and they want to get this. So, but in my world of wildest dreams, and I'm trying to have this happen, I would love to channel this into a Master's of Public Health room so they get some credit, and then they could do that if they wanted to get an MPH. Did that answer your question? There's a lot of interest in that. Yeah.
Oh, Maureen, congratulations on the chaplain. And question for you: this grant, this program that you have, is mainly focused on the dental hygienist. And is there any part on the nursing education?
Oh yeah, definitely. We have oral health is being integrated throughout the baccalaureate program and all the graduate level programs. So yeah, it's a big initiative because it's a school of nursing and dental hygiene.
Right.
So we have 2 departments, but we're under the same team. So it's really, we're in sync with that. So all of our, as I said, our advanced practice nurse practitioner students are learning this. All of our CNS students who are in the hospitals are learning to be looking in mouths and seeing what's going on there. In public health, population health, we call it now. This is a huge initiative of the Department of Health, so it fits nicely with all that.
So my follow-up question is very interesting. You guys have Department of Dental Hygiene and Nursing together. Can you let us know how does that happen? Like, since I'm dental hygiene and nursing, they are, very different. And how do they become a one department?
Well, I think that we have similar competencies that we are responsible for. I mean, preventative health is a big initiative of nursing. I mean, it is. So when you think what dental hygienists do, that's pretty much their very strong suit. They're in the trenches doing this every single day. I mean, cleaning teeth and looking at teeth and examining teeth. And then if they're allowed to do fluoride applications and that sort of thing by legislation. So to me, I grew up in the model of interprofessional care. I don't even know how to function with that. When I practiced here in the HIV practice, we had pharmacists, we had a case manager. Everybody was part of that team, so it fits nicely. So in terms of our joint educational efforts, yeah, we pull them in for research, we pull them in for all of that. So they're aware of that. We're getting them. In fact, two of the 2 faculty we have, the Sharon and the other one, they're presenting the results of the survey at a national conference in June. It's a dental hygiene conference. So yeah, so they're encouraged to do that, and we're kind of sponsoring them and helping them learn those skills. Yeah, so
One question. You have the post BS, what do you call it, EF, dental hygiene.
Expanded function.
Expand function,
Yeah.
expand function dental hygiene. After the 1 year, do they increase their scope of practice by the dental hygiene board?
Well, if they work in public centers, what we consider, so federally qualified health centers, Head Start, for example, those places, they can function pretty much, do applications and that sort of thing, fluoride applications in those settings without a dentist being physically on site. There's legislation now looking at even allowing them to do that without having the dentist have a first visit with the patient, because they're finding that it's just delaying them getting services. They could have some kind of preventative thing happen before they see the dentist, who has to do a whole exam on them. We're just started about 2 years ago, and it's expanding now, is teledentistry. And so Gavin Yoshida is working in the Department of Health with that, and we have a successful model that was started over on the Big Island on Kona with West Hawaii Dental, pediatric dental. We're going to roll that out, we think, and one of the things we wanted to write in this grant, like year 4 or 5, was to have teledentistry really be part of it. But our team said they're starting to do that in the Department of Health, so let's let them roll it out, and then they'll just have sites with us. So teledentistry will allow, again, in a state where we have maldistribution and not enough dentists, dental hygienists, to actually have those in the field who know how to use mobile equipment and do this, be hooked up with teledentistry, and then they would be covered for that as well.
Last question. Is there a general guideline or policy on oral health for nursing association, the American Nursing Association or something like that?
All of our competencies, I mean, when you look at what we have master's doctoral baccalaureate essentials that talk about all of the aspects of preventative care that would include oral health. So it's under the auspices of the competencies that we have. We don't have a skill checklist or anything like that. It's more of a competency level, like having a background in terms of research, understanding of the theory behind it, but then doing it. So they're all learning those things. It's part of what they have to do in community health, for example, and for our primary care nurse practitioners. It's part of health assessment. They all learn it as part of health assessment.
How about professional nursing organization? Do they have any endorsement?
ACNM, I mean, all of them, I think, pretty much. American Academy of Nurse Practitioners, American College of Nurse Midwives, they're all on the bandwagon about oral health, and they have statements about it. Yeah, they think it should be integrated.
Okay, great, thank you.
Any other questions?
Thank you.
Thank you.
Yeah.